Parkinson's disease is a progressive neurological disorder. Stay tuned to discover current neurotherapy and rehabilitation strategies for Parkinson's patients. Hi there, I'm Dr. Krista Burns, founder of the American Posture Institute and your host on the Virtual Neurology Summit. The purpose of the Virtual Neurology Summit is to provide healthcare professionals with brain-based solutions so you can get better clinical results with your patients. I'm honored to welcome our next guest expert. Dr. Rockman Chung is a board-certified chiropractic neurologist. He's been in private practice for over 18 years in San Francisco and is the owner and director of NeuroAccess Health, with a mission to transform lives through personalized neurotherapy and neurorehabilitation. At the age of 17, he was on the verge of becoming a professional skateboarder when recurrent injuries called him to question the longevity of the sport and introduced him to alternative medicine practices. This experience inspired him to join the field to help others recover from injuries and to optimize their brain health and performance. Today, he'll be sharing with us integrating neurotherapy and rehabilitation, real-world outcomes in Parkinson's disease. Dr. Chung, thank you so much for joining us as a speaker on the Virtual Neurology Summit. Please take it away.
So I'm excited to be here today to discuss real-world outcomes in Parkinson's disease with an integrated model of neurotherapy and rehabilitation. I'm just going to jump right into it due to limited time. So our overview is just to do a brief summary of Parkinson's disease and introduce you to the biomarkers utilizing EEG and quantitative EEG, and then a customized approach using neurotherapy and rehabilitation with a case study as an example. So Parkinson's disease, as many of you know, it's a chronic and progressive neurodegenerative disorder primarily affecting movement, but also causes a wide range of non-motor symptoms. The disease is characterized by a loss of dopamine-producing neurons in the brain, leading to both of these motor and non-motor symptoms. And these motor symptoms begin asymmetrically and then progress to be bilateral over time, while the non-motor symptoms actually often precede motor signs and significantly impact the quality of life. So mild cognitive impairment is also common and is present in about 27 to 40% of Parkinson's patients, even at early stages. And then there's cumulative prevalence of dementia in Parkinson's disease that can reach up to 78% after 8 years. So pathophysiology of Parkinson's disease in the early stages, it involves dopamine loss, and then this largely causes restriction to the ventrolateral region of the substantia nigra. So as the disease advances, this degeneration spreads to additional areas and also involves the accumulation of alpha-synuclein proteins that affects the cytoplasma of certain neurons across the brain and starts to interfere with function. So this aggregation is called Lewy bodies, and that's a very neuropathological hallmark within the disease, affecting cholinergic, monoaminergic, brainstem neurons, and olfactory neurons. So this leads to both the motor and non-motor symptoms, and also begins to affect limbic system and neocortex as advances neurodegeneration throughout the brain. So in Parkinson's disease, we can classify the motor and non-motor symptoms as following. In the motor symptoms, we have everything from the resting tremor, 4 to 6 hertz, the bradykinesia, which is the slowness of movement, the rigidity of muscle and movement that leads to postural instability, gait disturbances like hesitations and freezes and loss and falls, micrographia, small handwriting due to lack of motor control and rigidity, and hypomemia, which is loss of facial tone, and then speech and swallowing issues, dystonia in many cases, and the freezing of gait, like I mentioned. As far as the non-motor symptoms, we have depression and anxiety, cognitive impairment, sleep disturbance, autonomic dysfunction, like orthostatic hypotension, fatigue, pain, sensory symptoms, hallucinations and delusions, excessive sweating, and drooling. So a lot of very prominent and widespread symptoms that affect quality of life and mobility. So when we look at EEG and quantitative EEG, first want to just do an introduction really briefly. EEG is a direct measure of cortical neurons and their relationship to the thalamocortical system and other rhythmicities throughout the brain. It's originally used in medical neurology for identifying seizures and epilepsy, sleep disorders, severe altered states of consciousness. Now, due to imaging, it's not often used for tumors, but you can still identify those patterns related to space-occupying lesions and also vascular disruptions and severe encephalopathies. So this is a cap that we put on somebody's head with 20 electrodes so we can measure the activity from the surface of the head, all non-invasively. Then the quantitative EEG process is that after we do 10-minute recording of both eyes open and eyes closed, we then use software to then quantify and visualize and differentiate each of these frequency bands from slow to fast and how they're distributed across the surface of the head or brain. And we can measure 5 distinct different brainwave types. On the bottom, we have delta waves, which are predominant in deep wave sleep, where we release a lot of growth hormones, where we get the glymphatic control of releasing basically toxins and junk out of the brain. That's important for preventing neurodegeneration. But if we're in sleep, we're fluctuating between theta and delta waves. And the theta waves has been associated with like memory rehearsal, visualization, daydreaming. It's still a slow wave, and it also functions as like a carrier wave that can also grab information from other areas of the brain and integrate them as the brain is sharing information across regions. But it's still a slow wave, so it can reflect slowing of alpha or pathology related to slowing of firing rates throughout specific local regions of the brain. Alpha waves make up the predominant background rhythm of the brain because it's related to the thalamocortical system and all the sensory input related to that, vision, hearing, somatosensory information, visceral information, and integrating that and then controlling the autonomic nervous system as it integrates into the insula as well. And so the alpha waves are an important pacemaker for the brain. And since we have 2 hemispheres, if we see asymmetry in that, it's very important in identifying which sensory systems are involved and how bad that is. When we're looking at beta waves, we're talking about cortical activity, particularly related to executive functions, thinking, planning, but also motor movement and control. And then we go into the faster gamma states, which is an emergent property of the brain, when brain regions are communicating and working together in a shared function. So to simplify the basal ganglia in Parkinson's, we really have direct pathways that promote movements. We have indirect pathways that suppress it after we initiate it. And then we have a hyperdirect pathway, which is kind of like a rapid global stop mechanism. So initially we start with dopamine. That's just a modulation between all pathways that activates the nigra and then striatum and cortex, and then the cortex back down through the striatum and the globus pallidus, and then inhibiting the thalamus. The primary issue in Parkinson's is that we lose the nigra supply of dopamine, which ultimately leads to an excessive inhibition of the globus pallidus pars interna upon the thalamus. So the cortex starts to lose its pathway through the indirect pathway to then inhibit the GPI, and then the GPI becomes disinhibited, causing excessive inhibition upon the thalamus, leading to the slowness of movement and shutting down the sensory integration of the thalamic cortical system that I was referring to. So thalamocortical dysrhythmia in Parkinson's disease, this is a really important marker, not just in Parkinson's, but many other neurological conditions. It's a pathophysiological framework that describes the abnormal oscillatory activity between the thalamus and cortex. So it contributes to a range of all neuropsychiatric and neurological conditions that include Parkinson's. So when the abnormal resonance is disrupted between the thalamocortical system, either by decreased excitatory or increased inhibitory input at the thalamic level, like I described, this leads to thalamic neurons switching from a tonic firing rate to a burst firing rate. And then that burst firing occurs in a theta frequency at 3 to 6, 3 to 8 hertz cycles per second. So these oscillations then entrain the thalamo and cortical neurons And it's the same frequency as the resting tremor. So that's really important. And where is this origin of the resting tremor? Is this relationship of the basal ganglia and thalamus and cortex. So the oscillatory patterns in TCDs characterized by the increased theta wave activity that's to be generated, and then the abnormal coherence, or what we call phase amplitude coupling between higher frequencies in the gamma and beta range. So it's this hypersynchrony that causes both motor and non-motor symptoms. It also contributes to the cognitive and psychiatric symptoms as well. So in more detail, when we're looking at differentiating symptoms versus these different waveforms, the theta oscillations reflect negative symptoms like depression, hearing loss, hypoesthesia, and while the gamma frequency oscillations reflect positive symptoms like tinnitus, pain, and others. So the negative symptoms are also linked to the slow peak alpha, which I was referring to as the pacemaker of the brain. That's related to once that starts to slow due to the slowing rate of the thalamocortical system, that causes the alpha to slow down into the theta range, and this leads to more of the mood and cognitive issues, and also leads to a sensory deprivation of the thalamus to the cortex. So as this theta wave or thalamus is really losing sensory input, the theta wave acts as a carrier wave searching for that information, extending into the parahippocampus and looking then to use memory as a substitute for the loss of sensory information. So that's how this creates basically a spreading of the pathology and then also of the motor symptoms. So the tinnitus, pain, and movement, these mood-related information often reflect the high frequency oscillatory activity in the beta and gamma. But like I said, also it's tied to the slowing of the pacemaker and that alpha rhythmicity as well. So in this article, there's very spectrally distinct and spectrally different and spatially distinct areas of thalamocortical dysrhythmia and this coupling of theta and beta gamma oscillations that for each specific kind of neurological condition. So in the yellow, we see that this is represented in the somatosensory area, the sensory portion or the motor portion of the somatosensory cortex in yellow with both Parkinson's and pain, and the receptive sensory portion also in pain. The tinnitus is located in the superior temporal gyrus here, and then depression, pain, tinnitus, and Parkinson's, they all share this common origin in red to the right here in the dorsal anterior cingulate and also the subgenual anterior cingulate portions. And this is not unusual because it's the anterior cingulate that is connected to both insula that it functions as a salience network. The salience network is really to attend to things that are new. Some people call it the distress network, but it's really a way that we engage in the world that we see, tying to memory and sensory processing. But when there's something wrong or distressing, then there's a perseveration that happens with the anterior cingulate, and then that becomes this amplifying a feature where we get stuck or locked into symptom patterns. So in the early detection of Parkinson's disease, we can see this in these beta waves and the excessive synchrony between beta and gamma coupling. Furthermore, the beta activity reflects sleep disturbance because essentially this activity of beta activity really comes from the excessive firing the subthalamic nucleus in conjunction with the globus pallidus pars interna, firing through the thalamus, causing excessive beta activity that becomes widespread. This rises up through the cingulate cortex, and you can see this measured right at the top center of the head at CZ, but also distributed at many other sites. But CZ right at the top of the head, which is a very common marker or location to record EEG, but hopefully you're recording it from all sites, is a biomarker for insomnia. And it's also an area that we can directly train in neurofeedback to help with these features. But the point is being that it's the excessive beta activity that causes this sleep disruption onset and maintenance. Furthermore, it's actually Well, this article is really great because it reviews many of the EEG features as biomarkers related to Parkinson's. So like I said before, on the number one here in the summary of conclusions, that the slowing of the background activity in the alpha range starts to go into theta range, and also the loss of the beta and gamma power. So that further increases in PD. In the basal ganglia, this excessive synchrony between beta and gamma is really what's associated with the motor impairment. So I want to stop there and just reemphasize that. So related to the motor impairment, the stiffness, the rigidity, and the freezing of gait and falls is associated with that hypersynchrony in the beta range. And so when we use like medications like that activate dopamine or deep brain stimulation, then this will actually help basically reset and desynchronize that hypercoupling and help improve motor function. So today we're going to look at a non-invasive approach with neurotherapy and rehabilitation to also achieve that. So as these dopamine depleted motor circuitries in PD also cause this cortical and subcortical coupling at beta frequencies, this also is related to that akinetic nature that I was referring to. So I'm not going to go through all of these, but basically as we go to the bottom here at 5 and 6, basically we can see that the defining feature of the risk of dementia and PD is related to the slowing of the background rhythm in alpha and the excessive increase in the theta band. So this slowing occurs with the sensory processing. Again, thinking of it in terms more of like the thalamus is being shut down, it's losing sensory integration, the brain is searching for that information, but also that's slowing down the entire pacemaker of the brain, slowing the mental processing speed, which also prevents the brain from really being able to turn on, to be aroused, to excessive, to be kind of cognitively engaged. So when it comes to neurotherapy and rehabilitation, neurotherapy is an application of both neuromodulation and biofeedback to either stimulate, engage, and train brain regions of nervous system function. And then we use a variety of methods to modulate brain function and provide feedback about a person's physiological processes to improve self-regulation and optimize function with biofeedback. So we can categorize these here in the different techniques in neuromodulation, biofeedback, and rehabilitation. But I put the ones in bold that I'm going to really just be focusing on the case study today. So you have all these neuromodulation techniques like photobiomodulation, audiovisual entrainment, transcranial electrical stimulation, peripheral nerve stimulation, PMF. And then we have numerous biofeedback techniques such as neurofeedback, which is also known as EEG biofeedback, muscle biofeedback, known as EMG biofeedback, and then GVS, temperature. Those are related to also more specific, the sympathetic components that we can measure through biofeedback and direct specifically. And then all of the rehabilitation strategies through cognitive and sensory motor systems. So the bold ones we're going to review as far as how I'm going to apply them. So Ted Carrick did a research study using Parkinson's mice, and they found that using a far infrared blanket not only helped regenerate dopamine neurons, but also improved motor symptoms in a mouse model. So this article is a great review of some of the Parkinson's literature with neurofeedback. There isn't a lot of them, and they vary significantly as far as the locations. But going back to the history of neurofeedback, and one of the most powerful techniques is training the somatosensory rhythm, which is along the somatosensory cortex, and that range is between 12 to 17 hertz. When you reward that activity, that has been shown originally in the seminal paper to actually improve and stabilize seizures, but also prevent mice that are exposed to rocket fuel from getting seizures and dying from that rocket fuel exposure. So it ends up being neuroprotective by training that too. The same strategy with training SMR frequency was used in ADHD. So when you hear about neurofeedback in ADHD, they're often training the somatosensory rhythm along the somatosensory cortex on the left or right. So why is that important with ADHD is because this somatosensory rhythm creates a calm and attentive state. So you're processing sensory input from the thalamocortical system and your awareness of your environment, but you're not moving. It's the preceding of before action. So it calms hyperactivity as well. So regulating that thalamic input. So that could be very important in addressing hyperactivity in the motor system. So this is another great article about training sensory motor rhythm in primates. And similar to the rocket fuel and seizures of how neurofeedback was discovered with training SMR, this is one where now we have Parkinson's induced to primates. And first, what they did is train the primates, one group of them, with somatosensory uh, neurofeedback. And then another group, they didn't train them. And then they induced Parkinson's. And then found out which ones, how they responded. Basically, the primates who had neurofeedback training, not only did they have less impact and Parkinson features, but also it also maintained that difference between on and off medication when they provided L-DOPA as a treatment. So again, it's neuroprotective, but also helps adaptive afterwards. So that's important for everyone. So when we explore motor imagery is another powerful technique. When we imagine moving, we can use very high success rate with improving Parkinson's motor symptoms. In summary here of review out of 53 studies, in the experimental groups, 85%, 85.2% improved in the timed up and go task. And that's very significant improvement, again, out of 53 studies. So that's very important with just motor imagery. So what is motor imagery? I like to expand motor imagery in the way I use it. This is a great resource out of the NOE group. Graded motor imagery is a process of utilizing left-right discrimination, looking at an app and hand positions, and you're determining is that left or right hand, using that cortical system for about perception and awareness of movement. So it's at the cortical level. We're bypassing the basal ganglia and thalamus, so we're not causing excessive symptoms, or especially like dystonia. And then you follow that up with explicit motor imagery, where you imagine yourself and the sensory input of reaching and grasping something or doing specific types of hand movements, arm movements, body movements. And you can focus that on a very specific area of the body with the app and how you're directing the exercise. And I do that very specifically if I'm targeting a hand or a foot, or doing that in a sequential manner with my rehabilitation. And then that's followed up with mirror image therapy, where you put a mirror between the legs, and as you look in the mirror, the reflected image in the mirror looks like the opposite hand. So then you imagine and feel as if that other hand in the mirror, and you're moving both hands on either side of the mirror as you're doing specific motor sequences. So that staging of those three-step process is graded motor imagery. So we use that. And then we use this app to help. And then we follow that up with surface EMG biofeedback. So muscle biofeedback, very simple. There's a lot of technologies out there. This isn't exactly the one I use, but this is just a diagram to show that we place some sensors on the muscle groups of interest. And particularly, I like to use the ones that are opposing the ones that are over engaged, usually extensor groups versus flexor groups in the arm and or leg. So like in here, you can do a functional grasping task. And as the person engages the muscles, you hear a beeping or see the visual feedback on this device. So it's a very direct mind to muscle communication. So in our case study here, we have a 45-year-old female with Parkinson's disease. She has all the classic features, so it's early onset, which is often genetically passed down. This began to develop within the same year of her father's diagnosis, and so that was quite distressing. And she had all the classic features of stiffness, resting tremor, not quite freezing gait because this was early onset. But she had a whole history, which I'd treated her before, from post-concussive syndrome and migraines. And she had a long history of being very easily overwhelmed by sensory input and stressors. Once the Parkinson's began to express itself more in the motor sense, then that became very clear of like, oh, it was this hypersensitivity that was already developing, even though she didn't have any other non-motor symptoms like smell or constipation or whatnot. But then all these motor symptoms started to develop. So nuchal rigidity, primarily affecting the right arm and leg first, and then a year later started to begin affecting the left side. So this really began to affect her life with exercise and mobility, and even needing more regular chiropractic care to help maintain joint mobility. But so what else can we do though? Once we got a remote neurotherapy program in place, we can put all the pieces together. I start with the EEG here, and although you're not familiar with looking at the raw data, this is a snippet of like 12 seconds or so. The bottom few lines are the back of the head. The top of the graph is the front of the head. So on the bottom here, we can see the alpha rhythmicity here that just pops out from the background. Between each gray vertical line, the thicker gray ones is a second of time, and that's subdivided in fifths, so you can get visual estimates. But these are alpha rhythms at the back, and you can see them kind of ripple effect, called coherence as they go to the frontal regions. And that's related, again, if there's too much alpha coherence to back to the front, then the brain's not really turning cognitively on. And that's what we are always kind of hearing about alpha states. Alpha is a relaxed state. It's not a highly engaged cognitive state. And so if you're relaxed, but you want to be cognitively engaged and you have too much alpha coherence throughout the entire brain, that makes it really groggy, you get mood dysregulation. And that's where that kind of hallmark related to alpha rhythmicity is affecting cognitive states and mood. But I highlighted here in red along the left posterior temporal at PZ here, the bottom box, the middle's at the top at CZ, and then the T7 on the left. So basically T7 and P7 are just mid-temporal and left posterior temporal regions. And you can see these little sharp and slow waves here, and they're out of phase, meaning that their points in the wave are facing opposite to the one on CZ at the very top of the head. This is a phase reversal. So it means that in between those two lines, or in the brain between those two lines, is the source of that rhythm, which is in the insula. It's a common finding. It's often non-specific, but it reflects something irritative, often related to cerebrovascular ischemia and also dysregulation in the insula. Sometimes this also is reflective of vascular lesions and requires like an MRA, but it's very common in migraine, post-traumatic head injuries, and in this case, thalamocortical dysrhythmia. So and then I have this arrow pointing to all these little small spiky waves, and you see them everywhere. This is the beta activity, and it's everywhere. It usually just comes in little snippets or little bursts around the anterior cingulate in the frontal region, but not widespread like this. This is referring to that excessive beta activity as an early marker for Parkinson's and motor symptoms. So when we look at the spectra, so this here is looking at the cap that the individual is wearing. So each square is an electrode on the cap that's measuring these brain waves and using that quantitative method to then visually illustrate the brain waves slow to fast, left to right. It's hard to see all the colors of the spectra here, but in this box here, this is the left hemisphere. So the top is the left forehead, the back is the left back of the head, and so but then the right side on the right. So the dark red is the delta, bright red is theta, yellow is the alpha in the middle, and the beta frequencies are the green and blue that are very tiny to the right. So the only real peak we should see is the alpha peaks, and that's kind of a normal-ish distribution that we're seeing here. But what we're seeing when we're looking at the little head maps on the bottom is if I click on the features of each frequency band, I can make a map of how that's distributed. The first one on the left is really just the peak alpha or background alpha, and that's at 10.25 hertz. That's a normal range. But then there's the next one to it is 8.3 hertz, and there's a distribution more off to the right and posterior temporal region, which is a slowing of that alpha range, not quite into the theta, but it's slowing into it. The right side is more of the social emotional processing. We referred to that she had more sensory overwhelm and reactivity as that controls the autonomic nervous system. That kind of indicates also is common in post-traumatic stress. And then we have slower frequencies at 4 hertz and 2 hertz and towards the frontal regions. And then we have the faster beta activity at 25 and above hertz in the frontal, but also posterior regions as that's spreading. The last little graph or image on the right is the alpha coherence. You should only see in a normal distribution, it should be at 0.5. It's at 0.8 because it's just resonating across the entire brain and related to that kind of mood dysregulation and starts to affect cognition at that point. But we see this commonly. If someone's tired, then you'll get a lot of alpha coherence as well, but it's more common in Parkinson's too as the alpha slows down into theta. So to the left here is the theta beta ratio when we divide the slow waves from the fast and say this was initially used as like a marker for ADHD, but it's not ADHD specific. It's reflected too. Is there too much slow activity that's affecting sensory processing or cognitive function? The normal distribution should mostly just be at the top crown of the head, but you see this distribution is different in left frontal, right frontal, and posteriorly because it's starting to expand its territory in the thalamocortical dysrhythmia. So if we zoom into those same frequencies, now we can see the beta band in the green and blue, and notice how these peaks are everywhere, but they're a little bit larger on the left as well as surrounded by the delta in dark red and bright and theta in bright red. When you have more delta, that's related usually to white matter injury. So now you get slow wave activity. You see this in traumatic brain injury, but also in neurodegeneration. So that's that hypercoupling we're talking about between slow and fast waves and thalamocortical dysrhythmia. If we use S-Loretto, which is a way to do source localization, we can use this in software to say, okay, well, let's look for this thalamocortical dysrhythmia. So right here, we see an alpha wave, and then we see a beta range at 1920 hertz peak, and then another faster peak that goes from 30 and above hertz. So when you see each of these three peaks, it means that these are phase coupled and the source is coming from these regions. So you can see the topographic distribution here on the left and right frontal, but then this allows us to look and correlate that more two-dimensionally to the deep source. And here's the insula on the left. And then we have the middle and inferior temporal gyri, left inferior frontal gyrus. On the left side, we're seeing involvement here, more of the temporal and parietal regions. And then far to the right, it's extending into the somatosensory area now, where the face and hand and arm are. And this begins to spread. The cingulate cortex in the middle, it's not lit up in this image, but also that begins affected, as I said, that the thalamocortical system and that beta spreads up to the top, and the sleep disruption shows up at the top here as well in beta activity. So what do we do for treatments? We try to simplify things as much as possible to not overwhelm somebody. So we take them through stages, and it's all about stacking therapy. So neuromodulation is about priming using infrared light to help mitochondrial function. But as I said before, this particular gladiator blanket can activate stem cells to help potentially neurodegeneration or regeneration of dopamine neurons. So this was began to be used every day. Then we did neurofeedback to target that left mid-temporal to the CZ on the top to target that insula, but it's not just the insula, it's that entire thalamocortical dysrhythmia that's projecting from there and involving the insula and the temporal lobe and somatosensory cortex. So we're training 12 to 17 hertz in the somatosensory rhythm range. Some people classically like an ADHD, if you're just trying to induce a calm or less impulsive state, we do train to 12 to 15. But the full range is really 12 to 17. And if you include more 17, you're getting more into the beta range too, because you do want more of a drive related to motor initiation, but not too much where it's causing, contributing to the hypersynchrony that's present. So the beautiful thing about neurofeedback is you can both reward one frequency and inhibit the slow and fast ranges around it. And what does that mean? It means that you are desynchronizing, decoupling that hypersynchrony. That's the pathological feature. So, and then you keep on training that. So now you're opening that thalamocortical system back up from a cortical thalamic region. So we're tapping in from the top down to the midbrain or thalamus. And then we want to think about our rehab strategies the same way about how does sensory input affect the thalamus. I'll get to that in a second. We also do T5, T6 to CZ in a bipolar montage, which is between the left and right posterior temporal regions. Why? Is because we're training somatosensory rhythmicity, but only 12 to 15 here because I don't want to create hyperactivity in a sensory region. But also, when we get the slowing of the peak alpha, if we connect it to CZ and the posterior temporals, we're helping gently rise up that posterior dominant rhythm, that background alpha, because it's slowing down. And remember, a lot of the cognitive issues are related to that slowing alpha. There's other ways to increase that globally too, but this was a great technique. When you see them dysregulated, if you have slow alpha in the posterior temporal regions, it often relates to cerebral vascular ischemia, ischemic headaches, and other kind of fatigable symptoms and sensory overwhelm. So that's why I also do that location. Then we want to counterbalance this with the activating the cognitive system, particularly the anterior cingulate at the FZ in the front center. And so we don't want to overexcite them. So we're not going to reward in the beta range because they already have excessive beta. So we're going to do a gentle activation by inhibiting the slow range of 2 to 12 and the fast range of 20 to 4, 20 to 40, so that we're still getting that desynchronization, but still activating it. So now we're engaging that both salience and executive network and stabilizing the default mode network with the sensory integration behind it. So immediately we follow up with the graded motor imagery and we focus on the region or part of the body we want to emphasize first. Oftentimes, say, for example, if say the right leg is worse and it's having dystonic features, actually like this young woman was having, I start with the hand first because I want to gently open up the thalamus in that way. And then within 2 weeks, I switch to the foot following the neurofeedback. You can enhance this by doing gentle peripheral nerve stimulation. Common with chiropractic and physical therapy. You can use a 80 to 120 hertz, or you can use a somatosensory evoked stimulator, which basically you're just stimulating a peripheral nerve. And you're just doing it low threshold. So again, you're doing that to open up the thalamus. And you want to use that area involved that's less symptomatic. So if you have dystonia, you don't want to start there first because that's going to overreact and cause more inhibition upon the thalamus when you try to do sensory input. So you start in the same side, but the unaffected limb so that you can start to open that up. And then you can use other tactile stimulation with like vibration or tactile, or even taking a paper clip and just kind of like acupuncture or making a grid, just stimulating the skin. And the skin is the very large cortically represented. And so then you slap on some sensors for muscle biofeedback to get that mind-muscle connection. And you do simple movements, usually opposing the ones that are over-engaged. And I'll show an image of that. So here is the post results of the raw EEG. And if you kind of generally notice, like, oh, it looks a little less busy. A lot of that beta activity is gone. You still see a little bit of everywhere. So I just pointed a little arrow here to some small little beta waves, but it's not thick. We still have thalamocortical dysrhythmia in the left temporal region coming from the insula as well, but it's significantly better. If we overlap the one we have now, the initial one, the first one in May on top, you can see all the excessive beta activity, and behind it and the follow-up, it's just a lot calmer. So again, that's a direct reflection of improving motor symptoms and reflects the 80% improvement that we had with all of her rigidity and mobility within a month period. So this is the spectra map that allows us to compare the difference between May and June therapy time. So what we're looking at here is, again, the cap and the sensors on it. And what we're looking at is the blue line is what is original recording. The red line is what is present or current. Another way to measure to see the differences is that anything below this horizontal line has decreased since the previous recording. And anything above it, the horizontal line in color, is what has increased. Notice that we have mostly just a ton of decrease of the slow waves and alpha waves that shouldn't be here in the temporal region. a lot of decrease in the beta waves as well frontally. And what we have also is the yellow in the alpha range that's increasing in the back is actually a slightly faster alpha that's increasing. So everything that we want to see, even the right posterior temporal region related to a lot of that sensory, emotional, and excessive startle aspects, significantly more stable with decreased alpha and theta and extending everywhere. So this is a profound improvement. This is moving in all directions that we want to see. So the patient results really in motor function, I said, is approximately, this is what I'm going to improve my Parkinson's program by doing more regimented outcome measures with like peg boards and timed up and go tasks in addition to using the QEEG measures. But we had approximately 80% decrease in all the motor symptoms, and the non-motor functions also improved: attention and concentration, sleep, decreased startle, mood regulation, and sleep. So this is a really great outcome. Sometimes they still get a exacerbation of symptoms, but now they have a great therapy tool or set of tools that they can use to manage their symptoms and slow down the progression of the disease and how it affects their brain. So in summary, Parkinson's is a progressive neurodegenerative disorder. Thalamocortical dysrhythmia is characterized by increase in low-frequency theta rhythmicity and abnormal coherence with beta and gamma activity that's linked both to the motor and non-motor symptoms. And we can use EEG and QEEG to identify the TCD and use it to personalize therapeutic strategies, but also use it as an effective outcome measure. So then we want to use a multimodal approach, understanding the integration of the thalamus and cortex and sensory input to the thalamus to create a personalized approach that can lead to effective outcomes. So I hope that was fast enough. And I'll open it up to questions.
Thank you so much for your excellent presentation. I have tons of notes over here. I'm going to do a quick summary and then a couple of questions for you. Thank you for sharing, all the way from what the disease is, all the way through showing, how it progresses, and then of course some excellent techniques for measuring as well as working with patients. So we started by talking about with Parkinson's disease, how it's chronic and progressive, showing impairments of movement, but also non-motor symptoms. Loss of dopamine producing neurons, showing things like mild cognitive impairment is going to be common, and a cumulative prevalence of dementia in up to 78% of cases. Looking at the pathophysiology, so we see neuron loss restricting the ventrolateral substantia nigra, and accumulation of alpha-synuclein, which can form Lewy bodies. Motor symptoms include things like resting tremor, bradykinesia, postural instability, freezing and falls, micrographia, speech, and then swallowing issues. And the non-motor can be things like depression and anxiety, mild cognitive impairment, sleep disturbances, autonomic dysregulation, pain and fatigue, hallucinations, increased sweating, and drooling. And so looking at EEG, it's a direct measure of cortical neurons, utilizing 20 electrodes to measure activity. And then QEEG is quantifiable, so it's a software to quantify and visualize the frequency bands. It measures our brain waves like delta for deep sleep, growth hormones, and memory, theta for light sleep, creativity, and daydreaming, alpha for relaxed meditative visualization, kind of the pacemaker of the brain, and beta, motor functions, concentration, and focus, and then gamma, motor functions and higher cognitive states. So looking at the cortical basal ganglia pathways, we have direct, which promotes movement, indirect to suppress movement, hyperdirect, which is rapid global inhibition, and then dopamine helps modulate balance, and then disruption or imbalance in the pathway leads to excessive inhibition of the thalamus, which leads to slowness to movement and decreased sensory integration. So looking at thalamocortical dysrhythmia in Parkinson's disease patients, we see abnormal oscillatory activity between the thalamus and the cortex, a switch from tonic to burst firing rate, so the same frequency of the resting tremor. And then theta oscillations associated with things like depression and hearing loss, these are negative symptoms. And theta wave extends into the parahippocampus to use memory, which leads to a spread of pathology. And then gamma can be things like tinnitus and pain associated with positive symptoms. So we see spatial distinct areas of the thalamocortical dysrhythmia with sensory for Parkinson's and pain, and then depression, pain, tinnitus, and Parkinson's, all with the dorsal and the anterior cingulate. So it's associated with the insula and the salience network as well. We see early detection of Parkinson's disease features beta and gamma coupling, and so pathological beta is associated with sleep disturbances. You shared with us a great research paper of slowing of alpha range goes to the theta range. We see hypersynchrony between beta and gamma, leading to motor impairment, and dopamine-depleted motor circuitry being associated with akinetic, and slowing of background alpha and increase of theta band slows cortical processing and the pacemaker of the brain, and preventing arousal and cognitive engagement. You shared with us neurotherapy and rehabilitation, so an emphasis on neuromodulation and biofeedback to modulate brain function, giving feedback about physiologic processes to optimize function. So examples of neuromodulation, things like peripheral nerve stimulation, audio and visual, biofeedback, things like EMG, HRV, rehabilitation, things like visual, cognitive, proprioceptive, and tactile. And then with the sensory motor rhythm training is neuroprotective. So it creates a calm and awareness state, perceiving before action. So also good for things like ADHD. And then for Parkinson's disease, train with somatosensory neurofeedback. So you shared a great example of primates with Parkinson's disease. So with neurofeedback training, it maintained less Parkinson's symptoms for neuroprotection and adaptation. And then with motor imagery, so therapeutic for Parkinson's disease, seeing an 85% improvement in timed up and go tests, which is phenomenal. And then graded motor imagery, doing left and right discrimination. Then explicit motor imagery, so imagining yourself reaching or grasping, for example. And then mirror therapy, so the reflected image looks like the opposite hand and then perform the motor sequences. You can use the Recognize app as a great resource. And then this helps regain function. You shared with this EMG biofeedback device, so mind to muscle communication. And then an amazing case study looking at the EEG, we saw alpha rhythmicity ripple effect. The brain is not cognitively engaged. We saw the phase reversal, so a source of rhythm in the insula reflects dysregulation in the thalamocortical dysrhythmia. And then beta activity, an early marker for Parkinson's and motor symptoms. And then with hypercoupling of slow and fast waves. And so the treatment was neuromodulation, so infrared light for mitochondrial function, neurofeedback to target the insula and the thalamic cortical dysrhythmia, train the somatosensory rhythmicity, and then the anterior cingulate with gentle activation for salience and default mode network. And then rehabilitation, looking at graded motor imagery, peripheral nerve stimulation of the hand and foot, so things like tactile stimulation to help open up the thalamus. And then biofeedback, so surface EMG biofeedback, hand, foot, and others, and then HRV. And the results that you saw are just absolutely phenomenal. So 80% decrease of tremor and rigidity, improved motor coordination, balance, and gait, decreased startled mood regulation, better sleep, and improved attention and concentration. I mean, these are absolutely phenomenal results. So my question for you is, I believe you showed us with your case study that it was a month difference with the QEEG scan, with the EEG scan and then the QEEG measurement. When working with a Parkinson's patient, and if you're working with them over time, how often would you perform brain scans again in order to quantify the results that they're getting and or modify treatment as necessary?
Yeah, that's a great question. Also, wonderful summary. You just use that as the full presentation. But yeah, to answer your question, I either repeat the QEG process after 20 neurofeedback sessions. And so we just did this 3 times a week, so it was more condensed. So that's a really great frequency to do it at. And so we either just do it after every 20 sessions or, at least, minimally every 3 months if we're trying to do something therapeutic.
Wonderful. Thank you. And as we wrap up another great session today in the Virtual Neurology Summit, I'd like to acknowledge Dr. Chung for his excellent work in functional neurology. And to all of our viewers, I'd like to acknowledge you. Thank you for your commitment to brain-based correction and objective clinical results. I'm Dr. Krista, your host of the Virtual Neurology Summit. Be sure to check out the Postural Neurology program to get certified in brain-based postural correction. Stay tuned and we'll see you on the next Neuro Masterclass of the Virtual Neurology Summit.